This is SG2 Perspectives, a conversation with SG2 experts and industry thought leaders about the biggest trends in healthcare and what we all expect that's going to mean for the future of healthcare delivery.
AMCs, I think what we always hear from them, and what is such a great sort of embedded in their DNA is that they are discoverers, they're explorers, and these types of challenges are where they can play a strong role.
Welcome to SG2 Perspectives today. I'm your host, Trevor Durin, and I have my two colleagues, Mike Humphrey and Justin Cassidy, who lead our work with academic medical centers. Today, we're going to talk about themes from our AMC Summit around how AMCs are dealing with the industry's push for scale. I understand there were some interesting food choices available at both the tour and the hotels. So I can tell it was a fun event when people were talking about how great the food was when you came back. Anyway, you'll have a tough time matching that at next year's event.
Absolutely. Definitely.
Scale was also the theme of our executive summit this year. So why do we need to take a step back and dive deeper just for how our AMC members are dealing with scale?
It's a great question, Trevor. And I think in many ways, we've always known, and I think our AMC members have told us that AMCs are indeed different. I think if we were to put that into words, some of the added complexity in addition to what our other non-AMC members face, there are issues of cost. They're certainly 10 to 20% more expensive in terms of how they render care, and that has a lot to do with their multiple tripartite mission. And then obviously they deal with both those complex patients as well as some of the more medically complex patients. So it's not just those high-end tertiary patients. They really do serve almost like a Janus-like perspective, those patients that are complex and those that are also medically in need. So they perform a role that is a bit different and almost a multiplier. And therefore, when you talk about scale, you have to be respective to those unique aspects of an AMC, both their teaching, clinical, and research mission.
Right. So scale is good, but not everybody should take the same path. And I think that was the key finding as we explored this theme this year at the AMC Summit. And some of those paths were expanding physical footprints. Others were dealing with consumers, thinking about non-traditional collaborations, thinking about scaling brand and clinical expertise, or even innovation. So there were a lot of different kind of takes on scale. And I think that really best put was when Joan actually contributed during our discussion on the concept of clinical scale, which, as for the rest of SG2's membership, right, this is really the final frontier. This is really where it's at. And AMCs really have an opportunity to lead. As we think about scale as traditionally business-oriented, our colleagues at SG2 really do agree that most health systems have not spent enough time exploring that concept of clinical scale and thinking about how a consistent clinical product means making really tough decisions in service distribution sort of front.
Absolutely. And I think even in the attendees that were there, when we try to gauge their understanding of scale, we use an exercise some folks may be familiar with. It's called creating a word cloud. And it's sort of a singular word to describe what scale meant to them. And we got some of the expected answers right around efficiency, integration, growth, and opportunity. But I think it was some of the underlying or smaller, if you will, voted on things that were really, I think, good underpinnings around the concern of achieving scale. And that sort of confusion and madness.
Madness is my personal favorite. Whoever offered that, kudos to you. I think you're the one who is actually the most honest. The other one that I thought, Mike, was really intriguing was the concept of systemness. Yeah. This is a word that we're hearing over and over. It's a struggle to define that term, figure out what it means, how to achieve it. There's sort of a culturalization vibe. It's not what you do, but how you do it.
Absolutely. And the idea that scale and growth are synonymous, they're related, but not necessarily the same, right?
Exactly.
And I think the positive intent is what we were trying to uncover. We had a great day of folks really sharing the multiple dimensions of scale. And I think what we're seeing is some really good progress in AMC. So not only innovative in their clinical, but also this approach to scale.
Absolutely.
One of whom was the organization who was nice enough to co-host this with us, was Jefferson Health. The event was in Philly. Jefferson's grown a lot recently in traditional growth and in scale. So how are they thinking about scale?
Well, just to sort of reemphasize what you said, Trevor, growth has been tremendous. And in a short span of time, like in 3 years, think of an organization going from almost 1 billion to 9 billion, multiplying 9 times their revenue as an indicator of what they're doing.
Incredible.
It was the whole idea of sort of understanding where you were in the scale, developing scale, leveraging that scale, and then honestly, the aspirational tipping the scale. But there was a greater vision that was really focused on the clinical aspirations. And one thing we also learned is that many times in mergers and acquisitions, particularly between AMCs, which tend to have better financial positioning, not uniformly, but in most cases, that they didn't trade in the currency of dollars for capital investment. The currency was in board representation, so giving equal voice to the organizations that became part of the organization. So that idea of scale being built in terms of equal representation, clinical focus, I think were some of the takeaways from Dr. Meyer's presentation.
As we explore that concept of physical scale with Jefferson Health, we also had a tour that literally took us on a physical journey throughout Jefferson Health's system. And it was just fantastic. I mean, we had a bus tour to start the day. We actually drove through the downtown physical footprint, and we could see as Jefferson Health expanded the struggles that their cancer center had with just keeping up with that physical footprint. There was discussion as to the cancer patient's physical journey, literal physical journey through the various buildings is very difficult. And it's just because they're getting bigger. Then we actually went down to an area in South Philly called the Navy Yard. And this is an area of just rampant development. It's just a tremendous growth story in South Philly. It's an old military installation, actually, an old literal Navy Yard. And so there's still ships and dry docks. And so it's a story of urban renewal. Urban Outfitters is there, GlaxoSmithKline, WuXi AppTech is there, a gene therapy company from China, has 4 different buildings. So really a lot going on. Even a company called Tasty Cakes, which fed into the day, right, Mike?
Yep. Yeah, those were nice snacks. Whenever you host these, or whenever we go to one of these cities, we always have an AMC co-host it, and they're very nice about sort of introducing local flavors. So Tasty Cakes, for any of you who haven't been to Philadelphia, is a nice treat. A little bit like a Hostess, but they would say Tasty Cakes is better.
I know neither of you had a Tasty Cake.
Yeah,
so.
yeah, one or two.
And speaking about our hostesses, I mean, really special thanks to Monica and Lori who helped organize that tour. I mean, this was just a fantastic day. And it was just great to hear the opportunity and story from Jefferson Health's Navy Yard facility. And that facility is really a medical office building, an outpatient facility where the key selling points were very clear. Right, as we undertook this tour, we're driving by these 150 different companies that are in the Navy Yard, over 14,000 employees in that area. And the Jefferson Health Navy Yard facility is right in the middle of all of these. And so prime location, adjacent to employers, very convenient to highways, right? So it's right off I-95. And there's convenient parking, which we know is a frequent pain point for many. The facility itself, it's typical medical office building. So really the point of the tour wasn't to see that facility per se, but to see the environment surrounding it. It is a beautiful building, but it's also, I think, important to see that it's just physically close to all these employers.
Absolutely. And it's a great example of scale. It was a physical asset, but it also played a role in direct to employer, as you mentioned,
exactly.
Easy access,
Yep.
Very successful for that. As they seek to introduce residential to that, think about the young families that will be moving in there. A great way to be the provider of care, connector of care across the Jefferson Health system. So a really smart play on their part, and they are the exclusive provider of healthcare in that area.
Right.
So there was 3 sessions that I hope and think there was probably some themes and similarities. And that was MD Anderson, University of Michigan, and Mayo Clinic, all talking about partnerships and collaborations they've done. What were a few themes or takeaways that emerged?
Thinking about Mayo, Dan Berlin and Mark Larson gave an excellent talk on the Mayo Clinical Care Network. But really, this is nothing new, right? This is core to the concept of Mayo. Mayo first got its founding over 150 years ago. They've always been seeking clinical scale. The idea of bringing ideas together is really core to their mission. There's actually an excellent Ken Burns documentary out about a year ago on the Mayo Clinic called Faith, Hope, and Science. I don't know if either of you have seen it. Have you had the opportunity?
It's inspiring.
It's really cool. And, definitely our clients, I think anybody would be interested in it. But the idea is that the core is to really extend knowledge and information, not the physical footprint. That's the key take home from this talk for me. The point of culture is really to share and not to keep any sort of clinical innovation a secret or trade secret, right? This is not a business in the traditional sense. And so they have many different specific clinical care network offerings. There were over 10 of them listed. I was really intrigued by Dr. Larson in his conversation and around specifically the inflammatory bowel disease boards, just like molecular tumor boards. But the idea that with complex patients, it's just better to have a team behind them. And these clinical care networks can really help facilitate that. On the note of molecular tumor boards, we also heard from MD Anderson. Mike Brown and Mike Kupperman gave excellent talk on their cancer care network, similar to Mayo, but really laser focused on cancer care as the rest of MD Anderson's strategy is. And the idea there, I think the take home for me is that they're serving more patients from that network than they are in system. Mm-hmm. That was just striking, right? So you're achieving a lot greater scope by having these sorts of clinical care networks. I remember Mike Brown said that having a bit of independence and leeway with the University of Texas brand licensure was really key, such that you didn't always have to go to the university to make sure that you could extend the brand in certain ways, but also focusing on collaborations with communities such that patients could receive cancer care without having to undergo a lot of transportation. That was key. Striking is the focus on prevention from MD Anderson and the fact that they're now exporting expertise to different countries. I know they have collaborations with Mozambique in Africa and Brazil. So they're dealing with national health services and really thinking about international scale on that front. And finally, Mike Brown had an excellent quote that really opening clinical trials across the country would potentially be the most meaningful thing we could do. And that idea of clinical scale from a clinical trial perspective, I thought was simply intriguing. Any thoughts, Mike?
I think this example of just the clinical exportation of knowledge, that's really what scale, and can we tackle this on a broader perspective rather than just regionally or institution or system-based. And I think that fits well. One of the common themes was partnership and the different ways that people look at it, right? What I really genuinely appreciate about this story is that this was a story about working with potential competitors or longtime competitors. And in a sense, it's a story about maximizing the capacity for healthcare resources in a community rather than building or going your own way to try to seek that. So really the examples that they shared were in their market, they compete with a large faith-based system, Trinity. They have 2 hospitals there, one very large complex care institution and one much smaller. And the whole point is that most AMCs are at capacity, right? And could there be better sites of care for these patients? So the creative thing that they did was partner with St. Joe's, which is in Ann Arbor. And what they created was a unit that was dedicated to the medically complex, most typically geriatric patients. And when those patients presented at the U of M ED, they were given the option, if stable enough, to be transported to Trinity, St. Joe's, where they had this facility or this unit. And they were cared for University of Michigan physicians. So it wasn't as if they were perhaps losing the capabilities that a university would provide, but they would manage these patients in a much more suitable framework, a more coherent care management for these complex conditions, and at the same time free up capacity at the university for those patients that really needed that type of care. I just can't tell you how motivating it was to hear the type of collaboration from folks who had for many times been thinking independently about how they would address the needs of a market.
This actually reminds me of one of the questions you asked at the very start of the summit. You gave an informal poll and asked, how many of you are full, right? And every single person in the audience raised their hands. So decanting or decompressing AMC volume, really front and center to all.
Absolutely.
That dovetails nicely into Megan Young's presentation from partners around how their scale is really enabling them to move into value-based care. What do you think other AMCs can learn from what she shared?
I think this was a great story of a very thoughtful approach, almost like building blocks, foundational in many aspects. Much like the Jefferson journey was a very compressed time frame. So I think people sometimes ascribe to AMCs as being very conservative and risk averse in their thinking. I would say that's not necessarily true. And I think in this particular case around population health and its many definitions and scope, Partners has been very deliberate, but they've done it in a very fast fashion, moving from where they were just responding to maybe some Massachusetts legislation around the cost of care and doing some initial pilots to really becoming an organization that was not just building and expanding these pilots, but also doing so with the thought of how do we build analytics to measure this and how do we develop programs that engage the patients based upon their particular needs. And Megan shared with us sort of some areas where they've grown. And I think what's really amazing is that they are functioning in all four of the major payer categories. So they participate in commercial accountable alternative quality contracts. So they're going at risk for this commercial populations. They're involved with the Medicaid populations as well as the self-insured. Their partners, their employees are now involved in a self-insured program. And with Medicare, they're next generation ACO. So if you're going to be willing to move into this breadth and diversity of patient management and care management, you really need some underpinnings. And I think the two things that I really took away from this and what Megan would have said is key to that is they took a really significant look at segmentation of patients and their medical needs. Based upon those needs, then they were able to think about, well, not only do we need to think about how and where we meet the patient, but what are some of the wraparound issues like social determinants of health that are going to be critical to making sure the patient can engage and participate in their healthcare in an active and meaningful way. Segmenting those patients and then think about everything from healthy patients all the way up to the super utilizers, and then what programs might we need to make them successful. And I think some of the cool things that they did among many, they had a partners mobile observation unit. So rather than having those patients present at the ED, be perhaps admitted through or put into discharge status, or into observation status, and then perhaps even onto an inpatient stay unnecessarily, they would send out these nurses to do an evaluation when the patient might be reaching a critical stage. And so there was a lot of, if you will, technical and other aspects that were required. But
right, that really feeds into that hospital at home model, right? But it's observation at home.
It is.
And remember, Megan said during the prep that since 2017, they've had 250 to 300 patients in that sort of observation at home model. Really cool.
Absolutely. And think about the impact on unnecessary ED visits, right?
Exactly.
Another part of that, I think that's sometimes very difficult for not just AMCs, but all healthcare providers, is the whole behavioral health aspect. So they tackled it from really looking at the workforce that was required to manage these complex patients. So they introduced a new role. It's a mental health care coordinator who interfaces between the physicians, the psychiatrists, social workers, and the patients. But really that individual, almost like a nurse navigator for cancer, making sure that those needs were identified and met, documented, and followed in progress, in terms of metrics. Part of the story from Partners that I think was so impressive was the thoughtful way that they approached it, being very patient-centric and designing the programs and the tools around it.
Yeah, absolutely. We often hear about that embedded behavioral health component being the key secret sauce to medical home models, and here's a great example of that.
Another exciting session was a team from UCSF talking about their innovation work. What problems are they trying to use their innovation competency to solve and weave scale into all that?
It's such a great session. I think from UCSF, one of the key take-homes there for me was that they're, obtaining a significant amount of supplemental revenue with their commercialization efforts. And in fact, over $13 billion in startup valuations with companies affiliated. Right? With a B, billion. Yes, over 13 billion. I mean, that's crazy. I mean, of course, capitalizing on the proximity to Silicon Valley and all of that tech commercialization expertise, but still, the startup companies that they do actually help fund, they only have an expected success rate of 1 in 2 in 10. But that's all you need to be successful, right? Because when you're successful, you're very successful from that sort of drug development front. On the same note, I was really struck by the fact that UCSF is also being very mindful of achieving equitable access to this innovative care. And so that importance of health equity is really front and center to them. And there are 2 stories here that they shared that I thought were really intriguing. The first is that they really dug into and were starting to research homelessness, really to understand academically what's going on here. What are the core issues at stake and what can be done in a most impactful way to help alleviate that problem in San Francisco. And second, completely different story, basically the idea that they're going from bedside to clinical scale with cellular therapeutics for CAR T therapies, right? This is one of those novel, innovative gene therapies that are out on the market to help treat blood cancers. And the real cost here is the supply chain. The idea that you have to extract cells from a patient, grow them in a lab at scale, and then put them back into a patient, that's a very expensive process. It's not like a traditional drug, right, that you can just grow it in giant chemical vats. They actually have a collaboration where they're developed labs for this supply chain purpose with UC Davis to help bring down the costs of those innovative therapies. And that's something I think that will be very important in the years to come. And finally, excellent story, I think, really innovative, the idea of treating alpha thalassemia, which is a sickle cell-like disease, with stem cells in utero. So when the baby is still in the mother, right, gestating, you actually can treat with stem cell therapies to cure this sort of blood-based condition. Really exciting stuff. And finally, the idea that they're able to tap into quote unquote venture philanthropy via the Mark and Chan Zuckerberg Foundation is really very, very cool in terms of funding a lot of these innovations and research efforts.
Absolutely. And Justin, you just said something that reminded me. We also had a presentation from Rush University, and Justin mentioned how innovation is tackling homelessness. I think there's also innovation and community partnerships that AMCs are forging. And Rush gave a great example of what's called West Side United. And it's really, if you will, weaving together a fabric of the AMC, some partner community hospitals, as well as everything from faith-based organizations, Meals on Wheels, food banks, behavioralists, any type of intervention or support that patients typically might need to, again, actively participate. And where the rubber really hits the road, we had two sightings of these statistics. On the west side of Chicago versus the downtown area, typically referred to as the Gold Coast, there's a 16-year difference in life expectancy. We were further surprised to hear Jefferson say that in certain parts of Philadelphia, there's a 20-year difference. And so,
just incredible. I mean, truly, that statistic alone, absolutely, it's striking that within just a few miles, you have a lower life expectancy. It's absolutely astounding.
It is. And all the things that we're talking about in terms of growth, scale, and how we deliver care, where we deliver care, I think, and we all are increasingly believing that if we don't start tackling this at that early, sort of really at the roots of these issues, we're going to have little impact in terms of how care evolves. You know, we even talked with some of our chief strategy officers and how they're melding and developing their teams to really adapt to this range of challenges, right? And so we had three folks join us, one from Duke, one from Freighter, and another from Northwestern, really talking about how they're developing skills and mindsets among their team to prepare them to address these issues. And that was also insightful in terms of how they organize their time, how they've changed over time to really take on really these questions of scale.
Yeah, no, I think the panel was absolutely excellent as well. I mean, Morgan Jones from Duke had a great quote that they have and try to instigate living, breathing strategic plans that are embedded into their operations. And Karen Eston from Freighter said that the biggest trick is not to get distracted.
Yeah.
And Ann Hall from Northwestern said that they really have one big team concept to help prevent burnout across the board and really help achieve communication with digital forms and videos throughout their system. Really intriguing stuff.
Always lots of exciting stuff to hear when we give our exciting AMC members the forum to share some of the cool stuff that they're doing. I'm sure there were some great conversations over dinner and ongoing with some of the members. Any kind of closing thoughts about how they're thinking about scale as either an opportunity or a challenge?
I think they see it as a challenge that is an opportunity for them. AMCs, I think what we always hear from them, and what is such a great sort of embedded in their DNA is that they are discoverers, they're explorers, and these types of challenges are where they can play a strong role. I think you could look across any of the conversations or the presentations that were had that day and take away a piece that they are leading, they're exploring, and they're learning constantly. And I think particularly as we think about how the medical workforce evolves, that's going to play key in terms of the education and the expansion of their role. So I think AMCs really see this as an opportunity. It's challenging and frustrating because of some of the practical things that sometimes get in our way.
Potential madness.
Exactly. Madness, going back to that first word cloud. But I think it's in their DNA to be leaders in these challenges.
Yeah, I think it was actually pretty simple. You know, in looking and considering and looking at our notes and examining all of our great organizations and faculty of the day, it seemed as though a common theme was developing, and that's just simply that the mission of your organization needs to align with your strategic ambitions for scale.
Yeah, and it would be interesting, that the tripartite mission that, clinical education and research,
exactly,
we're now adding in that fourth leg of the stool, if you will, which will make it probably a sturdier stool, and that really is focused on those aspects of the social determinants of health. So they're evolving and becoming much more thoughtful of those needs.
Mike and Justin, you guys are the best. Thanks for giving us this download from the exciting AMC Summit in 2019. Look forward to having you both back on SG2 Perspective soon.
Great. Thanks, Trevor.
Thanks for the opportunity to share, Trevor.
Thanks so much for joining us today for this episode of SG2 Perspectives, where SG2 experts and industry thought leaders explore the drivers of tomorrow's healthcare strategies to inform today's decision makers. I've been your host, Trevor Durin. Contact us anytime by sending an email to sg2perspectives@sg2.com. SG2 revolutionized demand forecasting with the Impact of Change forecast in 2001, and today we're the healthcare industry's premier strategy advisory firm. To learn more, visit sg2.com. Thanks for tuning in. Hope to see you again soon.